Usually when you think about a medication, you probably picture it like a master key. You swallow a pill, it dissolves, gets into your bloodstream, and then it just, kind of unlocks every single door in your body that it happens to fit into.
Right, yeah, like if you take a painkiller, you want it to numb your knee, your back, your headache, all of it.
Exactly. All of it. But a master key can be a massive liability, right? Sometimes you don't want every door open. Sometimes you need a smart key card, one that is like meticulously programmed to open one specific door in a highly secure building while simultaneously triggering the deadbolts on all the other doors.
I love that analogy. It's so true.
Yeah, and today we are diving into a stack of sources: FDA clinical pharmacology reviews, pharmacokinetic studies, expert endocrinology papers that outline a drug with exactly that kind of brilliant split personality. The drug is called ospemifene.
Which is such a fascinating compound.
It really is. Our mission today, for you listening, is to figure out how a single oral pill can act like a powerful healing estrogen in your pelvis, act like a molecular blocker in your chest, and completely alter its behavior based on how well your liver is functioning.
It is a perfect case study in how we are moving away from that old shotgun approach to medicine and towards highly targeted in pharmacology. Because, if you open the wrong hormonal doors in the human body, the consequences can be catastrophic.
Right. Cancer risks, all of that.
Exactly.
Yeah.
We need drugs to know exactly where they're going, and more importantly, where they absolutely shouldn't go.
Well, before we track this drug's journey through the body, we really have to look at the destination. We need to understand the environment it's being sent in to fix. Our sources refer to the condition as genitourinary syndrome of menopause, or GSM.
Yeah, and you might also see it in the literature as vulvovaginal atrophy. Basically, think about what happens during menopause. Systemic estrogen levels don't just dip a little, they plummet by up to 90%.
Which is a massive shock to the system.
A huge shock, because estrogen isn't just a reproductive hormone. It's essentially the structural maintenance worker for the vaginal epithelium, which is the tissue lining the vagina. It keeps that tissue thick, elastic, healthy.
And without that constant maintenance worker around, the sources make it clear this isn't just some subtle cosmetic change. The actual microscopic architecture of the tissue just completely breaks down.
It does. So in a healthy premenopausal state, the vaginal tissue is made up predominantly of superficial and intermediate cells.
Like, imagine them as microscopic, plump, fluid-filled bricks that build up this sturdy, cushioned wall.
That's exactly it. But after menopause, because of that severe estrogen drop, those mature cells disappear. They are replaced by what we call parabasal cells, which are essentially these immature, really dry cells.
Wow, okay.
Yeah, so the tissue wall itself becomes very thin, very pale, and incredibly fragile.
And that structural collapse triggers this whole domino effect with the local microbiome, right?
Oh, it completely crashes the local ecosystem. So the natural protective bacteria in the vagina, the lactobacilli, they rely on a very specific food source. They feed on glycogen.
Which is this sugar.
Right, a sugar that's naturally released when those mature, plump, superficial cells break down. The lactobacilli eat the glycogen, and then they produce lactic acid as a byproduct.
Okay, so if the estrogen vanishes, those mature cells vanish. And no mature cells means no glycogen, which means the bacteria starve and the lactic acid production just completely stops.
Spot on. And when that lactic acid drops, the vaginal pH spikes from a healthy, highly acidic 3.8 up to a much more alkaline state, often above 4.5 or 5.0.
And that acid is crucial, isn't it?
Absolutely. That acidic moat is the body's natural defense mechanism. When it dries up, the tissue becomes highly susceptible to irritation, microtears, chronic infections.
Yeah.
But the most prominent symptom, and really what drives a lot of patients to finally seek help, is dyspareunia.
The medical term for pain during sex.
Yes. Moderate to severe pain during sexual intercourse, stemming directly from that severe dryness and loss of elasticity.
And the surveys in our stack note that many people just think, well, this is a permanent, unavoidable part of aging. They think they just have to live with the pain, which is tragic. But this is where ospemifene enters the picture. And it's entirely different from standard systemic hormone replacement therapy. It's categorized as a SERM.
A selective estrogen receptor modulator. And that word selective is doing a monumental amount of heavy lifting there.
Yeah, I bet.
So ospemifene binds to human estrogen receptors, specifically the alpha and beta receptors. But in the vaginal tissue, it acts exclusively as an agonist.
Okay, let's unpack this. In pharmacology, an agonist is basically an activator. So think of ospemifene as that chemical VIP pass we talked about earlier.
I like that.
Right. Actual natural estrogen is an all-access pass. It opens every single estrogen door in the body. It turns on the receptors in the vagina, which is great, but it also turns on the estrogen receptors in the breast and the uterus.
And if you introduce excess systemic estrogen into a postmenopausal body, you run a real risk of overstimulating those tissues and triggering cancers.
Exactly. But ospemifene's VIP pass is coded specifically to turn the lights back on in the pelvic mucosa while being aggressively denied entry everywhere else.
What's fascinating here is the sheer speed and efficiency of the cellular transformation that VIP pass triggers once it reaches the pelvis. I mean, when ospemifene binds to those local vaginal receptors, it effectively reverses the biological clock of that specific tissue.
It's just wild to think about a pill doing that.
Right? Clinical trials, notably the Phase 3 Sunrise program, showed this distinct, rapid disappearance of those dry, immature parabasal cells. And in their place, the body starts rapidly producing mature, mucified superficial and intermediate cells all over again.
Rebuilding the brick wall from the inside out.
Precisely. It increases the vaginal wall thickness, the natural elasticity returns, and because those mature cells are back, the glycogen returns. The lactobacilli feed on it, the lactic acid is produced, and the vaginal pH drops right back down to that healthy, protective, acidic state.
And it achieves this localized structural healing entirely through a daily oral pill, bypassing the need for topical estrogen creams or vaginal rings, which, a lot of people find messy or inconvenient or just uncomfortable to apply.
It's a huge quality of life upgrade for a lot of patients.
Definitely. So we have a really clear picture of how beautifully this works at the destination. But to get that VIP pass down to the pelvic mucosa, an oral drug doesn't just teleport there. It has to survive a brutal journey first.
Oh, absolutely.
When you swallow that pill, before it ever reaches the general bloodstream to head to the pelvis, it has to get through the body's ultimate chemical security checkpoint, the liver.
Yeah, and the liver is decidedly not a passive filter. It's a highly aggressive metabolic processing plant. Virtually anything you take orally and absorbed through the gut is immediately routed straight to the liver via the portal vein before it ever hits general systemic circulation.
The first pass metabolism.
Exactly, first pass metabolism.
And the FDA pharmacokinetic studies highlight something completely wild about how this drug enters that system. Ospemifene is incredibly dependent on the environment in your stomach when you swallow it. Like, the prescribing instructions explicitly say it must be taken with food.
Yeah, it's not a suggestion, it's a rule.
Right, but the data gets very specific. Taking ospemifene with a high-fat, high-calorie meal, something heavy, like a cheeseburger and fries, that actually increases its peak concentration in the blood by 2.3 to 2.5-fold compared to taking it on an empty stomach.
It's a massive jump. The overall exposure, which is the total cumulative amount of drug your body actually absorbs and utilizes over time, it almost doubles when taken with that heavy, high-fat meal. It's a massive shift in bioavailability.
Why is that, though? Just because of the fat?
Yeah, ospemifene is highly lipophilic, meaning it dissolves in fats. So that greasy meal essentially acts as a highly efficient carrier vehicle, shuttling the drug across the intestinal wall and into the system much faster and in much higher quantities.
Okay, wait, hold on. If taking this pill with a cheeseburger practically triples the amount of the drug hitting the bloodstream at its absolute peak, how does the liver handle that sudden, massive influx?
A great question.
I mean, why doesn't that cause a toxic spike in the patient's system? You're literally dumping double the medication into the blood just because of what you had for lunch.
You are, but it survives that spike because of two very clever physiological safety valves. First is the concept of steady-state pharmacokinetics. You aren't just taking this drug once. It's a daily 60-milligram dose.
Right, it's a daily routine.
Exactly. The FDA data shows that it takes about 7 days of repeated daily dosing for the drug to reach a steady equilibrium in the body, where the amount going in basically equals the amount being cleared out. But the real hero, the mechanism that prevents that cheeseburger spike from becoming a toxic event, is protein binding.
Ah, the serum proteins acting as a sponge.
Yes, the sponge. So once ospemifene is absorbed into the blood, it doesn't just float around freely. Over 99% of it immediately binds to proteins in the blood plasma, primarily albumin. You could visualize these proteins as a massive fleet of transport ships, or like you said, a giant sponge.
Just soaking it all up.
They grab onto the drug molecules and hold them firmly locked away. Only the tiny unbound fraction, which is less than 1% of the total drug, is clinically active and free to actually interact with receptors.
Oh, wow. So even if a high-fat meal dumps an absolute avalanche of the drug into your portal vein all at once, the protein sponge just absorbs the excess. It locks it away and keeps the active free-floating levels in the blood perfectly steady.
Exactly. It acts as a biological buffer.
Yeah.
It releases the active drug slowly and steadily over time, completely smoothing out those extreme dietary spikes. Now, as the liver slowly processes the drug out of that sponge, it uses a family of enzymes called cytochrome P450.
Right.
You can think of these enzymes as the liver's specialized dismantling crew.
And the sources specifically named CYP3A4, CYP2C9, and CYP2C19. Why does it matter exactly which enzymes are doing the dismantling?
It matters heavily for drug interactions.
Uh-huh.
If a patient is taking another medication that inhibits CYP3A4, for example, the dismantling crew is essentially out on strike, and the ospemifene will just build up in the system.
Got it.
But under normal conditions, these enzymes snip and alter the ospemifene molecule, metabolizing it. And in doing so, they convert it into its major active metabolite, which is called 4-hydroxyospemifene.
And that metabolite isn't just waste, right? It also has estrogen-like effects.
It does, yeah. It's an active contributor to the healing of the vaginal tissue, working right alongside the parent drug. Then, after the liver does its work, the drug has a terminal half-life of about 26 hours, meaning it takes 26 hours for half of it to be cleared from the system.
And where does it go?
Eventually, the liver excretes the vast majority of the processed drug, about 75%, out into the feces, with a very small fraction leaving via the urine.
Okay, so the protein sponge mechanism safely buffers the drug against a high-fat cheeseburger, and the dismantling crew processes it out. But that assumes the liver is completely healthy. What happens if the liver itself, the body's metabolic processing plant, is fundamentally broken?
Now, that is the ultimate stress test for any targeted medication. If a patient has a malfunctioning liver that just can't clear the drug, does this precise, targeted SERM suddenly build up and become a systemic danger?
Well, let's look at the hepatic impairment data from the FDA reviews. They tested the drug on patients with varying levels of liver disease using the Child-Pugh scoring system.
Right, and the Child-Pugh system is basically a clinical grading scale for liver failure. It looks at factors like bilirubin levels, how well the blood is clotting, and whether fluid is pooling in the abdomen, just to determine exactly how compromised the organ is.
And in mild hepatic impairment, which is known as Child-Pugh Class A, the system handles it fine, right? Exposure to the drug actually dropped slightly. The total area under the curve went down by about 9%.
Yeah, mild impairment is fine.
But moderate liver impairment, Child-Pugh Class B, tells a completely different story. The liver's elimination process just severely bogs down. The half-life of the drug jumps from around 26 to 35 hours in a healthy person to nearly 44 hours.
It's a huge delay. And because the drug is lingering in the liver for so much longer, those CYP enzymes are just continuously churning out that active metabolite we talked about. The pharmacokinetic data shows that moderate liver impairment causes a massive 72% increase in the overall exposure to 4-hydroxyospemifene.
Okay, here's where it gets really interesting, and honestly where my alarm bells started going off when I was reading this.
I can guess why.
Yeah. If a sluggish liver means you have 72% more of this active estrogenic drug floating around your bloodstream, doesn't that inherently increase the risk of rogue estrogenic effects in places we absolutely don't want them?
It's a totally valid concern.
Right, because estrogen feeds breast tumors. It thickens the uterine lining. If the liver isn't clearing the drug and is pumping out 72% more of it, aren't we massively increasing the risk of endometrial hyperplasia or breast cancer? Like, how does more of this drug not equal more danger?
If we connect this to the bigger picture, this is where the sheer brilliance of SERM tissue selectivity really shines. Logic dictates that a 72% spike in an estrogen-like compound would be dangerous. But the clinical safety data proves otherwise.
It really does.
The drug remains remarkably safe for the breast and the uterus, even at these highly elevated impaired liver concentrations.
But how is that chemically possible? If there's 72% more of it, shouldn't it be forcing those doors open just by sheer volume?
You would think so, but it comes down to the physical, three-dimensional architecture of the molecule itself. Ospemifene belongs to a chemical class called triphenylethylines. Now, older SERMs in this class, like tamoxifen, which is famous for its breast cancer benefits but infamous for increasing the risk of uterine cancer, they share a similar backbone. But ospemifene has a slight vital structural modification.
The chlorine atom.
Yes, one single atom. But in molecular biology, adding one specific chlorine atom is like putting a heavy steel steering wheel lock on a car. It physically prevents the molecule from bending and turning in a way that would be dangerous. Researchers speculate that this specific chlorine atom alters how ospemifene interacts with cellular DNA.
Okay, how so?
It physically blocks the formation of what we call DNA adducts, which are pieces of DNA covalently bonded to a cancer-causing chemical.
Wow. So this tiny structural tweak, literally one single atom, is acting as a chemical leash, preventing the mutations that cause cancer.
Exactly. Because of that rigid, specific three-dimensional shape, when ospemifene floats into the uterus, it binds to the estrogen receptors and essentially just sits there. It has a completely neutral effect on the endometrium. The long-term phase 3 trials showed no clinically significant stimulation of the endometrial lining and no hyperplasia.
That's huge.
It's a massive breakthrough because it means women with intact uteri don't have to take a secondary protective progestogen medication alongside it, which is normally required with regular estrogen therapy to prevent uterine cancer.
And what happens when those molecules reach the breast tissue?
In the breast, its shape causes it to act as a pure antagonist, a blocker. The source data shows that in vitro models using human breast adenocarcinoma cells, ospemifene actually inhibited the growth of the tumors. In animal models with estrogen-positive mammary tumors, it actively suppressed tumor development.
So let's be back to our VIP pass analogy for a second. The physical shape of this keycard is so rigid and so perfectly engineered that even if a malfunctioning liver accidentally prints 1,000,000 extra copies of the pass and floods the bloodstream with them, it physically doesn't matter.
Right, it doesn't matter at all.
The card simply does not fit into the card readers at the breast tissue or the uterus. The doors stay locked no matter how many keycards are swiping at them.
Perfect way to put it. Higher concentrations in the blood do not result in a loss of molecular discipline. The drug's physical structure acts as the ultimate built-in safety net against hepatic impairment. It remains a powerful healing agonist in the vagina and a rigid neutral blocker everywhere else it matters.
Which brings us back to you, listening right now. Why does this incredibly detailed look at the split personality of ospemifene actually matter? Because it is a masterclass in modern pharmacology. We are finally moving past the era of just throwing systemic hormones at the body, hoping for the best, and desperately managing the collateral damage.
We really are.
We are looking at a reality where we can design a drug that is taken orally, navigates the liver's aggressive metabolic gauntlet, survives massive concentration spikes from something as simple as eating a cheeseburger or as complex as moderate liver failure, and yet it never loses its programming. It maintains the precise molecular discipline to rebuild pelvic tissue from the inside out without ever threatening the breast or the uterus.
It is the absolute triumph of rational drug design. But it also leaves us with a fascinating, almost science fiction level path forward to think about. We've seen how ospemifene uses its specific triphenylethylamine structure and that crucial chlorine atom to selectively heal the pelvic mucosa while acting as a brick wall in breast tissue.
Yeah.
If we can achieve this incredible level of tissue-specific hacking and navigate the liver's bottlenecks so effectively, could future SERMs be engineered to bypass the liver's constraints entirely and target other estrogen-starved systems? Could we design a SERM that targets the brain, offering a targeted treatment for postmenopausal cognitive decline or brain fog without ever triggering a single systemic risk to the rest of the body?
That's incredible to think about.
That is the next frontier of this science.
Yeah.
And it's entirely within our reach.